Hello, welcome to the EKG Guy and welcome to the EKG of the Week. I hope you're having a wonderful week and I'm glad you could join us. So this week's case is a 91-year-old female that presents with intermittent palpitations. Her presenting EKG is shown here. Now before we get started, let's review the approach we've been using to interpret EKGs. So notice we have the patient's clinical presentation, then the EKG below it. On the right side of the screen, you'll see a list of different areas of the EKG that we'll go through before making our final interpretation. Now first, notice that there's the regularity of the rhythm. That is, are we dealing with a regular or irregular rhythm? And if it's irregular, is it regularly irregular or irregularly irregular? Next, we look at the heart rate, okay? And in this case, we simply want to determine the rate of the rhythm. Then we'll look at the rhythm origin. That is, where's the rhythm actually starting from within the heart? Then we have to determine the ventricular or QRS axis, which could help us with our differential diagnosis. And then there's the atrial, atrioventricular, and interventricular conduction, looking at if conduction is normal or abnormal in any area of the heart. Then we'll move on to the waveforms, which would include all the waves, segments, and intervals. And lastly, anything else, meaning is there anything else that we've missed or still need to mention, such as abnormal R-wave progression or a transitional zone in the precordial leads, okay? So after that, we'll use all this information that we've gathered to make a final interpretation of the EKG. Now I want to pause the video and I want you to take a few minutes to go through the EKG yourself. Try to answer different areas of this, okay? And then when you're ready, start the video and we'll go through it together. Alright, so our 91-year-old female that presents with intermittent palpitations in this EKG. So now let's walk through it. Alright, so first we're going to look at the regularity of the rhythm. So on first impression of this EKG, you probably notice that the rhythm appears quite regular, except for a premature complex that we'll talk about later. Therefore, we would technically call this an irregular rhythm, and because there is regularity to the overall complexes, we call this a regularly irregular rhythm. Okay, so let's look at that now. Okay, so this is a regularly irregular rhythm. Okay. All right, so why is that? Remember, when we deal with regularities, we're looking at what is the most often the R to R interval, okay? And why do we use the R to R interval? Okay, we use it because the QRS complexes tend to show the greatest potential on the EKG, okay? You could do this with the P to P interval, which is from one P wave to the next, but we'll use the R to R interval here, okay? So remember, the R wave is the first positive deflection after a P wave, okay? So this is an R wave here. Here we're looking at the V5, okay? So this is our R to R interval from one R wave to the next, okay? And we're looking, is that duration between those R to R waves the same throughout, okay? Meaning, is the next R to R interval the same as the one that precedes it, okay? So from one R wave to the next, all right? And then we go from this to the next one, from one R wave to the one that follows it, and then throughout this EKG, okay? And you would see that if you use calipers or use the piece of paper to measure these R to R intervals, you'd see that they're pretty much the same. The only thing that we see different is that when we have this complex here that is present, okay? So you can see that, and it's coming a little earlier than we would expect, but then the next one comes where we would expect it, meaning from this R wave to the one that comes after, that's actually two R to R intervals. And we'll see that's what's called a compensatory pause, okay? But everything that comes after this is, again, the same R to R interval afterwards. So because this is an irregular rhythm, but has regularity to it, we call this a regularly irregular rhythm, okay? Hopefully that makes sense. So what did you get for the heart rate? Well, there's a couple ways we can calculate it normally if we have a completely regular rhythm. But because we have that premature complex, we will use one way because this is technically irregular, okay? So what we'll do is count the number of complexes going across the EKG, multiply that number by 6 to get an estimate of the ventricular rate. And then because we know that the standard EKG represents 10 seconds in total duration, okay? So let's go through that now. All right, so I'll erase this so it's cleared up, okay, and there's no confusion. So remember, the standard EKG from the beginning, all right, so from this point all the way to the end represents 10 seconds, okay? And if you multiply 10 seconds by 6, that gives you 60 seconds, which is 1 minute, okay? So what we said is if we count the complexes going across, which we'll do now, so 1, 2, 3, and notice we're counting the ventricular complexes, okay? This is 4, 5, 6, 7, 8, 9, 10, we'll count that premature complex there, 11, 12, 13, okay? So we said we would take that number, 13, multiply by 6, okay, because this is 10 seconds and we want in beats per minute. So 13 times 6, what does that give you? 78 beats per minute, okay? So that's a good estimate of the rate, and the actual rate here was 79 beats per minute. So we'll just write that up here. We did 13 times 6, which was 78 beats per minute. The actual heart rate that was calculated by the machine was 79 beats per minute. So you can see that's a very close approximation, okay? So we'll erase this here, but hopefully that makes sense. And that's the ventricular rate we found because we used the ventricular complexes, the QRS complexes, to calculate the rate, all right? So now to the rhythm origin. Well, we see that we have narrow QRS complexes, so it must be supraventricular in origin, that is originating from above the ventricles. We can also make out clearly defined similar shaped P waves, all right? So what we have to ask ourselves, are we dealing with sinus rhythm? Okay, so let's see. How do we know if we're dealing with sinus rhythm? So first of all, what is sinus rhythm? Remember, if we have our box diagram of our heart, okay, this is our right atrium, this is our left atrium, our right ventricle and left ventricle. Where does the sinus node sit? Well, it sits up here in the right atrium, near the superior vena cava, okay, and then we have these internodal pathways, okay, that comes to a AV node. Remember, we have the Bachmann bundle that comes and depolarizes the left atrium. From the AV node, we have a His bundle that then bifurcates into a right bundle branch that innervates the right ventricle. And then we have this left bundle branch that splits off into two subdivisions, the left anterior fascicle and the left posterior fascicle, okay? And those innervate the left ventricle. Now, both those fascicles and the right bundle branch then go to the ventricular Purkinje fibers that innervate the cardiomyocytes, and that's how the depolarization wave spreads. So when we talk about sinus rhythm, that means that we're originating from here, the sinoatrial or sinus node. And notice that our conduction pathway heads this way, okay, towards our AV node, which is here, all right? So if we were to superimpose the right atrium on this, okay, so imagine this is our right atrium here that we're putting on this vector here, okay, our sinus node again sitting up in this area here, and the vector heading in this direction, you would see that the normal axis or the normal P wave axis, which represents the atrial depolarization, is between 0 degrees, okay, and actually about here, positive 75 degrees. So this is where that normal axis, that P wave axis, heads in that direction, okay? And that's where we would want to see the sinus P waves heading in that direction, okay, coming from that sinus node. And what you'll want to do is now put where those leads are placed. So remember, lead 1 is here at 0 degrees, okay? And then you have here positive 90 degrees where the lead AVF, the positive end sits, okay? And then this would be plus or minus 180 degrees, and this is negative degrees. And we'll talk about that when we talk about ventricular access next, okay? So because that depolarization waves heading in this direction towards lead 1, we want to see positive upright P waves in lead 1, okay? We may see them in AVF. Lead 2 sits here at positive 60 degrees. And then remember those leads in the horizontal plane, those leftward leads, which are V4, V5, and V6, okay? Again, the impulse heading in that direction, so we should see upright P waves in those leads as well. Now remember, AVR sits here, okay, and because the impulse is heading away from it, we should see negative P waves in AVR. So now let's go back to our EKG and see if we see this, okay? So this is all for sinus rhythm, again, originating from that sinus node. So lead 1 is here, okay, so you can slightly see some P waves there, okay, and lead 2 is here, okay. These are all upright P waves, all similar morphology. Here's V4, V5, and V6 that you see these upright P waves, okay? And we can also see them in AVF, okay, right there. And then in AVR, we said we would see those inverted P waves. So here's AVR, and that's why you see these negative inverted P waves. So another thing for sinus rhythm to exist is that the P waves have to have that same morphology as we saw, and you want a P wave preceding each QRS complex, okay? And you want to have one P wave for every QRS complex. So again, if we look down here, we can use this V5. So here's a P wave, okay? And then here's our QRS complex, P wave, QRS complex, P wave, QRS complex, okay? And if you went throughout this whole thing, you would see that there's a P wave always preceding a QRS complex, except in this area here, and we'll talk about that complex shortly, okay? So what we can say here is we do in fact have sinus rhythm. So the rhythm origin is from the sinus node, okay? So sinus rhythm, except in this area. That will leave that for a discussion later. Now let's look at the ventricular or QRS axis. Now you should have gotten a physiologic left axis deviation that is still within normal limits. The actual value here was negative 17 degrees, which means it's still within our normal limits for adults, okay? So it was actually, so physiologic, okay? Leftward axis, and it was negative 17 degrees, okay? Still within that normal limit for adults. So we'll erase this here and look at how do we find the ventricular or QRS axis, okay? All right. So one of the main leads we want to look at, and there's multiple ways you can find access, but the best way, and sometimes the easiest, is looking at leads 1 and AVF, and then if you have to, look at lead 2. So we'll do that here, okay? So remember, this is 0 degrees, where positive end of lead 1 sits. This is positive 90 degrees, where the positive end of AVF is. This was plus or minus 180 degrees, and this is negative 90 degrees. Now remember, normal axis lies between negative 30 degrees and positive 105 or 110 degrees, okay? Meaning that all this here is considered normal axis. Once you start getting in this region here, this would be more of a left axis deviation, and this is what we call right axis deviation, and this quadrant is extreme axis deviation, okay, or sometimes referred to as no man's land. Still a rare thing. Sometimes you can see it in ventricular tachycardia or VTAC, okay? So in this case, we have to find the axis. So we're going to look at leads 1, okay, and AVF first. So here's lead 1. Notice that we have these QRS complexes that are upright and they're positive. That means we're going to be heading towards the positive end of lead 1, okay, and then we're going to look at AVF. And notice that in AVF, these are negative complexes, meaning that we're going away from this positive end towards negative 90. That means our axis lies somewhere in this region. And notice that we can either be in this leftward axis, this abnormal left axis deviation, or we can be in this region here, which we sometimes refer to as a physiologic left axis deviation, okay? Still within normal limits, but in that quadrant of left axis deviation, okay? Now in children, you often don't see this because they have that right ventricular predominance, okay? But as we get older, this patient here is 91 degrees. We don't know her medical history. She may have hypertension, and she may be shifting. As we get older, we tend to go more leftward in the axis, okay? All right, so let's see here. What is the axis? Is it normal or is it in this region? Well, what we have to do is now look at another lead, and that's lead 2. Now lead 2 comes down here. This is lead 2, and it sits at 60 degrees, okay? And what's important about lead 2 is that because it's at 60 degrees, if we take the perpendicular to it, it actually goes right along this, which is that negative 30 degrees. Meaning if lead 2 is positive, okay, it'll be heading in this direction towards that lead and put us in that normal axis range. Or if it's negative, it will head this way and put us in that pathologic leftward axis range, okay? So we look at lead 2. So here's lead 2, and notice that it's upright and positive, okay? So upright and positive, meaning that it's going to put us within this region here, okay? And that should make sense. Remember what we said, the EKG machine actually measured it at negative 17 degrees, which means that it's somewhere here, about here. This is negative 17 degrees, okay? So we have at normal axis here, still that physiologic leftward shift, but still within normal limits for adults. Hopefully that makes sense, okay? Now let's move on to atrial conduction. Well, typically we'll look at leads 2 and V1 for P-wave or atrial abnormalities, as they appear to be most evident in those leads. The P-waves in these leads that we see here are normal in amplitude and duration. Okay, normal P wave duration is typically defined as less than 120 milliseconds or 3 small boxes. Now, if the P wave duration is prolonged, we are thinking more left atrial abnormalities. This is because the terminal portion of the P wave represents left atrial depolarization, while that initial portion of the P wave represents right atrial depolarization. Anyways, it's normal here, so we won't get into too much detail with that. Okay, so we have normal atrial conduction. All right, now how about atrioventricular or AV conduction? Well, in this case, we're looking for any conduction delays as the impulse travels between the atria and the ventricles. Because the majority of the PR interval generally represents the AV nodal conduction, we look there. Okay, so the normal PR interval in adults, which we're dealing with here, okay, is between 120 and 200 milliseconds, or 3 to 5 small boxes. Here, the PR interval is within normal limits and was found to be measured at 160 milliseconds. Okay, so if you just look here, okay, here's lead 2, and you can see clearly that it is again within normal limits. Okay, it's less than 200 milliseconds, so we have a normal PR interval. Okay, and it was actually on average 160 milliseconds, so less than 200 milliseconds. So that's what we consider normal AV conduction. Let's move on to intraventricular or IV conduction. Here we're looking at the duration of the QRS complexes. Normal QRS duration is often between 70 and 110 milliseconds, or about 2 to 3 small boxes. Some may consider the upper limit to be 120 milliseconds. Anyways, the main thing here we're looking for with intraventricular conduction is whether or not the QRS interval is prolonged. Here we can see that we have narrow QRS complexes that appear within normal limits. In fact, the QRS duration here is 74 milliseconds on average. So that helps to confirm that we do have normal intraventricular conduction. Okay, and that does not include this beat here. Okay, so on average they are normal, meaning that all these complexes here, the duration of them are within normal limits. Okay, so it was normal and on average 74 milliseconds, so clearly less than 120 milliseconds. All right, so how about the waveforms? Okay, so we said that the P waves were normal with no significant P wave prolongation or increase in amplitude in leads 2 or V1. No abnormal Q waves or QS complexes are present here. The T waves are present, they're asymmetric, and they appear normal. Generally, the T wave amplitude decreases with age and tends to be lower in females than males, and it is typically considered abnormal if it's less than 10% of the R wave amplitude. Now, the T wave amplitude is typically greatest in leads V2 through V3, okay, and on average is 0.3 to 0.4 millivolts in adult women. All right, now the PR segment, okay, it's not significantly depressed or elevated anywhere. The PR and QRS intervals we said were within normal limits, and the QRS amplitude appears normal here. Okay, so no evidence of ventricular hypertrophy on the EKG. Now the ST segment does not appear to be significantly elevated or depressed anywhere. And lastly, with the waveforms, we have the QT interval, which here is within normal limits. The QTC interval was measured to be 405 milliseconds. Remember, normal QTC interval in males is less than 440 milliseconds, and in females, which we're dealing with here, is less than 460 milliseconds. So we have a normal QTC interval, so there are no major waveform abnormalities. Okay, so we will just write no other ones. Okay, so no other waveform abnormalities in this case. So is there anything else that we're missing here? Well, how about the R wave progression in the precordial leads? Normally, R wave amplitude should progressively increase from leads V1 through V5, which is for the most part seen here. Okay, so notice that our R waves here are slowly increasing in amplitude. All right, maybe not so much from V3 to V4, but overall, we would probably consider this a normal R wave progression. Okay. Now, how about the transitional zone in the precordial leads? Well, this happens to be occurring in this case between V4 and V5. And what do we mean by the transitional zone? Well, the transitional zone is simply the precordial lead area where the QRS transitions from being mostly negative to mostly positive, with the actual transition area to be where the QRS is isoelectric. Normally, the transition occurs between leads V3 and V4. If it occurs earlier than V3, we call this a counterclockwise rotation or early transition. If it occurs after lead V4, then we call that a clockwise rotation or late transition. Therefore, because the transition appears to occur somewhere between leads V4 and V5, we would actually call this a clockwise or late transition. Okay, so we'll write that here. So again, remember we said that we had a normal R wave progression. Okay, and then in terms of the transitional zone, we said we had a clockwise rotation or late transition, okay, because it occurs between V4 and V5. So just so you're aware of what we mean by this transition, what we mean is that in the precordial leads, which are these leads here, V1 through V6, the chest leads, okay, we want to see the lead where it goes from mostly negative to mostly positive, okay, and the most isoelectric lead, if we see an isoelectric lead, that's where the transition occurs. So V1, notice that the QRS complex is mostly negative, okay, same thing in V2, mostly negative complexes. V3, again, the negative portion is still greater, so these are negative. When we get to V4, if you were to measure these out, again, this would still be mostly negative. All right, but then when we get to V5, you start to see more predominantly positive complexes, okay? And because we're going from negative to positive from V4 to V5, our transitional zone occurs somewhere between there, okay? So that's a clockwise or late transition. Now, one thing to keep in mind with R wave progression and transitional zone is that this is highly dependent on lead placement. All right, now there's one thing we have yet to mention. We keep bringing it up, but that's that complex that appears to be coming sooner than expected and has that compensatory pause. This is a premature ventricular complex, or PVC. Notice that it's not preceded by a P wave and is a wide complex. It is a wide complex because it's originating from within the ventricles and outside the normal conduction pathway. You can think of the normal conduction pathway as being the highway system and the fastest pathway to depolarize the ventricles, which typically gives you a narrow QRS complex, as we see in most of these complexes, okay? However, if you're originating from within the ventricles, as we see in these complexes here, okay, now you are outside and you're taking those back roads to the ventricles to depolarize them and originating from within them, okay? So it's going to be much longer to depolarize all of the ventricles, all right, and therefore you have these wide ventricular complexes that result, okay? So we're outside of our normal conduction system, originating from somewhere within our ventricles. So if we draw our system, remember these are our ventricles. Normally we start up here and come down, but if we're coming from some point within our ventricles, okay, somewhere you have this ectopic focus, one of these that then fires, but it's outside that conduction system, and you have the slow cell-to-cell depolarization, and that's why you have these wide complexes that result, okay? All right, so just to erase, so you can see that these are all wide complexes, and notice that the beat is coming earlier than expected, okay? Normally we would expect the QRS to maybe come here, but it's occurring there, okay? And this is that big T wave that you see there. So you have a QRS complex coming sooner than expected, no P wave seen there, okay? So no P wave, and again, then you have the beat that comes after, and again, this would be compensatory pause because this would be two R to R intervals, okay? So from this to this is an R to R interval, okay? But this is two R to R intervals, meaning that we have a compensatory pause, and it's something we typically see with PVCs, or premature ventricular complexes, okay? Now, just a few points on PVCs, and you can find much more information on this in our EKG course if you're still interested. So again, PVCs are early beats originating from an ectopic focus within the ventricles. The general rule is that the fastest pacemaker controls the heart, okay? And in this case, it's coming from the ventricles. Now, in terms of mechanism, there's usually an unusual irritability of an automatic pacemaker cell within the ventricles that then sets off. Now, some causes that you can see it from are anxiety, myocardial ischemia, hypokalemia, meaning low serum potassium levels, hypomagnesemia, okay, so low magnesium levels in the blood, drugs such as excess caffeine, okay, beta agonists, as well as digoxin toxicity, all right, among many other causes, okay. Now, in terms of clinical significance of this, they're often benign unless you have a prolonged QT, and that can lead to torsades, all right. You typically don't need treatment with these, and you may have palpitations associated with them, and that may trigger a reentrant tachyarrhythmia. Now notice that our patient here had palpitations, and that does make sense that we are seeing this PVC here. Maybe if we had more of an EKG or had a Holter monitor, we might see a few more when she's experiencing those symptoms. Okay, we mentioned there's that compensatory pause, so the overall timing of the beats is not affected. There's discordant ST and T wave changes. And what do we mean by discordance? Well, notice that in our normal complexes, we have these upright QRS complexes, mostly positive up, and the T wave is also upright. However, when we look at our PVC, or the premature ventricular contraction, notice that our QRS complex is mostly negative, but then our T wave is mostly positive. So we call that discordant, and that's something you tend to see with premature ventricular complexes. Remember, normally we have concordance between the ST and T waves. Okay, so this is discordant ST T wave changes, and hopefully that makes sense there. Another few points with these is that they result in an irregular rhythm, as we saw here. It made it regularly irregular. Okay, the rate again depends on the underlying rhythm, which we found to be about 80 beats per minute here. Okay, there tends to be no P waves, as we see here. Okay, and so notice these are all the same PVCs occurring at the same time because of that temporal relationship of the EKG. There may be retrograde P waves because secondary to retrograde conduction, meaning that the PVC that started from the ventricle, so maybe it started here, depolarized throughout here, and maybe it got conducted backwards and you saw some atrial depolarization. Okay, so we call that a retrograde conduction. So you can see sometimes a retrograde P wave. Okay, now in terms of the P wave to QRS ratio, there's often none unless you have that retrograde P wave conduction present. Okay, there's no PR interval because there's no P wave. The QRS interval we said is prolonged, so greater than 110 milliseconds, or at least sometimes some will consider that 120 milliseconds, as we see here, and that abnormal QRS morphology. Okay, notice that the QRS complexes have a different morphology. Okay, these complexes here have a different morphologies than those that surround it. Okay, so that's one thing to know. There tends to be no grouping or drop to beats present. Now in terms of terminology of these PVCs, when we call them unifocal, that means that they have one focus, so coming from one area in the ventricles, and they have one morphology. Whereas if we call them multifocal, that means there's more than one foci and there has multiple morphologies associated with them. If you have a bigeminy PVCs, that means that every second beat is a PVC. If we have something called trigeminy, that means every third beat is, and quadrigeminies, every fourth beat would be a PVC. Okay. You may hear of couplet PVCs, and that just means 2 consecutive premature ventricular complexes, or triplet means 3 consecutive PVCs. Okay. So hopefully that makes sense. Now there's one last thing that we can touch on. It's a little more advanced, and that has to do with where is the origin of the PVC coming from. Okay, and the origin, if it's coming from the right ventricle, remember these are ventricular contractions. Okay, so they're coming from the ventricles down here, and are they coming from the right ventricle or the left ventricle? Okay, well you can tell by often looking at lead V1. All right, so in lead V1, you're looking at the complex, okay, and if it has a dominant S wave, then we would say that it is likely coming from the right ventricle. If it has a dominant R wave, then we would say that it is coming from the left ventricle. Okay, so let's look at this. Here's lead V1, and notice our PVC here has a mostly negative complex. Okay, so it's mostly negative QRS complex. That means that it is coming from the right ventricle, dominant S wave. Okay, and why is that? Well, imagine lead V1 sitting over that right ventricle. It's one of our right precordial leads. Okay, and if you have the ectopic focus originating from within the right ventricle, it's going to head away from it. Okay, so if you imagine V1 somewhere in this region and you have the complex originating from here, it's going to head away from it, so you'll see a negative complex. Okay, whereas if you have the left ventricle, which sits more posteriorly, and you have an ectopic focus, it's going to depolarize more anteriorly, and you'll see an upright dominant R wave. Okay, so a little more advanced, but some of you may like that stuff, so Yeah, hopefully that was helpful. Okay, so that's premature ventricular contractions, and let's look at our final interpretation here. So we said we have a regular rhythm with sinus origin in the rate is 79 beats per minute. The ventricular axis we said is physiologically normal, okay, although has that leftward shift. There is normal atrial, AV, and IV conduction. There are no abnormal waveforms, and the R wave progression in transitional zone, okay, that we saw here, that normal R wave progression, the clockwise or late transition in the precordial leads, okay? And then we saw that we had the premature ventricular contraction, or PVC, present there. So this is an EKG that shows sinus rhythm and a PVC, but is otherwise normal. So great job if you're able to get that on your own. Now, when compared to the previous EKG, the differences here included a PVC present and a decrease in the PR interval. And you always want to look back at a previous EKG to make sure that there are no significant differences that you may be missing from the most current one. All right, so let's write our final interpretation and finish up here. Okay, so we'll make some room. So our final interpretation is that we said we have sinus rhythm. Okay, we noticed that we had that PVC present that we pointed out, and then we said that it is an otherwise normal ECG, okay? And then when compared to the previous one, what did we say? We said now we have the PVC present that wasn't there on the previous one. So we want to note that. And we said that there was a decrease in the PR interval. Okay, so in conclusion, our 91-year-old female that presents with this intermittent palpitations has an EKG showing sinus rhythm and premature ventricular complexes. Well, that's the end of this EKG of the week, okay, and I hope you learned something. Have a wonderful week. Please don't forget to like this video and leave a comment below if you like what we're doing. In fact, many of you have asked how you can help us out. Really, the best way would be to simply subscribe and share this resource with your friends. You get free access to more than 300 videos. There's also a community of over 150,000 of us like-minded individuals on Facebook, so stop over and join the EKG Guy's Facebook community. If you need a crash course on EKGs, we launched our new EKG course. Check the link below if you're interested. The original cost is around $150, and I believe I made it less than $20 for a limited time. I may be biased, but after reading nearly every EKG textbook on the market, I think this is by far the best EKG series to take you from the beginner level to a physician level. I've even included our pediatric lectures. Anyways, check it out for yourself. I think you'll really enjoy it, and a number of medical schools and hospitals are beginning to use it. If you are a part of an institution, please contact us because we're giving a limited number of schools and hospitals free access to provide feedback and improve our course. And in that case, you can get the course for free. So leave a comment below and get in touch with us. And of course, check out our brand new website, ekg.md, the premier EKG resource for medical professionals, where you can find more lessons and practice. That is www.ekg.md. Last but certainly not least, your feedback is incredibly helpful, and your kind words are always an encouragement on those long days. So let us know how we're doing. Thank you again for your support. It is truly appreciated. We're the largest, fastest growing EKG resource in the world.